Awesome. Welcome to the Myrna Method live stream. I'm registered Dietitian Myrna Haag. My goal is to bring you nutrition information that can greatly impact your life. In this video, we're going to talk about insulin resistance and why all the confusion. Healthcare professionals that are maybe not understanding the science or maybe only part of the science, but we're just not getting it right. So Sam, if you'll switch it over to the PowerPoint, let's get moving. All right, let's talk about insulin resistance because I think most people might know what it means from a terminology standpoint, but not necessarily from the biochemistry standpoint. So let's talk about the terminology. What is insulin resistant? Insulin resistance is a condition in which the body cells become less responsive to the hormone insulin. Insulin, of course, is the hormone that regulates blood sugar levels by transporting glucose from the bloodstream into cells for energy. And here's one thing that most people know, because if they have obesity or they're struggling with diabetes, that it is really tough to lose weight, especially as you age. So let's talk about diabetes in general, because insulin resistance is the precursor to type 2 diabetes. So what is diabetes? When muscle cells and certain brain cells do not have access to sugar, that's basically point it right there. And insulin is the hormone. It's like a key that allows sugar in the muscles and in brain cells, because it's really the muscle and brain cells that are really hungry for this stuff. And it's the receptor sites that allow that hormone to attach to that all the action takes place. So let's start with type 1 diabetes. Type 1 diabetes is when insulin isn't working. We don't supply enough insulin, and therefore the body cannot move the sugar into the muscle or the brain cells because there's no hormone to do it. But the receptor sites are working just fine. Type 2 and type 3 diabetes, which we'll talk about type 3 diabetes, which is also known as Alzheimer's, is when the actual receptor sites are not working. So insulin's working fine. It attaches to the receptor site, but the message doesn't happen. The message to the muscle and to the brain cells to allow the sugar inside doesn't take place because the receptor site isn't functioning. So let's look at the biochemistry, because I think when you have a visual on how it all works, then we can really understand the controversies and really start to break it down. When you eat a carbohydrate, the body releases it into the bloodstream as glucose, which is sugar, and immediately the body releases the hormone insulin. And as I said before, insulin rushes to muscle cells, attaches to a receptor site, certain neuronal cells, attaches to the receptor site, sends a message through the cell, and allows the transporter to the surface of the cell. And when that transporter is at the surface of the cell, wonderful things happen. Number one, sugar is allowed in the muscle cell. But what happens with type 2 diabetes or type 3, Alzheimer's, is the message never gets to the transporter because the insulin receptor site is disabled. And why is it disabled? What is disabling it is excess fatty acids. Where are these excess fatty acids coming from? Excess body fat, which is why I'm going to talk about some of the controversy, because when you lose excess body fat, you're losing millions of fatty acids that would normally be in circulation. And these fatty acids get into circulation, accumulate in non-fat tissue. A fat cell is a fat tissue, but a muscle cell is not. And what can happen are these fatty acids begin to accumulate in non-fat tissues that's not designed for a lot of excess fatty acids, and they differentiate and they become a type of fat called a ceramide. They actually change their structure. These ceramides are then the fats that are responsible for getting up into that receptor, not just in muscle cells, but also in brain cells. And there's a lot of studies on Alzheimer's that these ceramides can be very troubling for certain neuronal cells. It can cause destruction. It can cause proteins to grow, these plaques in the brain. So these ceramides in themselves are damaging. These ceramides travel in the plasma. They can disrupt other things like the pancreas. They can actually contribute to adult onset type 1 diabetes because they can destroy the pancreas's ability to make insulin. They can also affect valves in the heart. So these ceramides are not a good thing. And when you have diabetes or insulin resistance, because insulin resistance happens maybe at 30 or 40%, they haven't really diagnosed you as a diabetic yet, but you're certainly on your way, but you're still going to have ceramides. You're still going to have this intrusion of these fats that have differentiated within this muscle cell. So what happens with type 2 diabetes is we do have that risk factor. This also is a very arthrogenic compound, meaning it can get up into the artery wall and cause inflammation and plaque forming. So what happens is this message to the cell to allow the transport to the surface never takes place. So insulin then begins to build in the bloodstream because sugar keeps knocking on the muscle door trying to get in. Same within certain neuronal cells. And the body sees more sugar in the blood. You didn't eat more. Let me just make that clear. But you certainly have a situation where you have now a lot of insulin in the blood. So you have a lot of sugar in the blood. You have a lot of insulin in the blood. The sugar is not going where it's supposed to, even though the insulin is attaching to receptor sites. The message is not getting to the muscle cell to allow the sugar inside. Long and behold, that sugar ends up in fat cells. And with insulin resistance, we typically see fat cells in the abdominal area. This is where we tend to get most of these excessive weight gain with insulin resistance. You start getting the belly fat. But the worst part about it is you're getting this whole entourage of these fats that we really don't want in the system. But here's where it gets confusing. We've got a lot of insulin. We got a lot of sugar in the blood. This is never a good thing. Never a good thing. But I really want to give the impression here that everybody is blaming insulin and sugar as being the culprit. And really, they're not. The root cause of this disease is up in the receptor sites that has these fats that we don't particularly want at all in our body. And with type 2 diabetes, when you start getting these fats, you are going to be at risk for kidney issues, heart issues, because ceramides do that. And also dementia. There's a higher association with type 2 diabetes. So what most healthcare professionals want to see is an immediate resolve of just let's get rid of the insulin. Let's get rid of the insulin in the blood. Oh, I want to mention one more thing. When you have all this insulin in the blood, you are hungry because that's what insulin does. So what a terrible situation here. You've got sugar in the blood that's going in the fat cells, so you're getting even fatter. You've got more insulin in the blood, and you're getting even hungrier. And by the way, muscle cells are so unhappy because muscles actually want carbs. They actually want sugar inside them. And it's a function of nutrition that's really important, and I'm going to get to that. So muscles start telling the brain to crave more sugar, so you're in a heap load of trouble here. And so obviously what they think the immediate fix is, and I can understand, is let's just remove the insulin out of the blood and the sugar by having a diet of low carbs, high fat. Well, let's get really clear here that the fat's causing the problem. So a diet in high fat, low carbs will appear to fix the problem because the insulin won't be in the blood. And obviously the sugar's not in the blood because we're not really eating a lot of it. Muscles are extremely unhappy. So know that there's going to be an assault there on cravings. But when you get rid of a lot of insulin, people will not have that immediate rush for food, because insulin does trigger that. So I can understand why a low-carb, high-fat diet could seem like the perfect answer. Not to mention that you lose a lot of weight, you're going to get rid of a lot of fat cells. Millions of fatty acids that would normally circulate will go away when you get rid of body fat. But it's not long-term. And I want to explain why. Short term, it seems like a great thing because obviously if you get rid of more fat off your body, you're going to have less ceramides. but they don't look at the whole picture. They're just looking at the short term. And I do want to talk about these ceramides a little bit because I always want to bring some studies. So if you're here for the first time, you've never heard me talk about ceramides or insulin resistance. In this study, it talks about excess fatty acid accumulation in non-adipose tissue, which means non-fat tissue, is a hallmark of metabolic disease. I just explained to you what metabolic disease, that is metabolic disease, also known as metabolic syndrome, causes obesity. We'll go into that, but that's metabolic disease. And it says in this study, when elevated lipid levels exceed the cell's capacity to store utilized fatty acids, a lipid toxic response happens. And it's characterized by a destruction of the organelle's membrane. This is an activation area that these ceramides go and really cause what's called apoptosis, somewhat cell death. But that's where the insulin receptor site is located. And at the bottom of the study, it says it right there. While the fatty acids and their metabolites play a key role in membrane structure, because we know fats are important, but it's when you have an excess. It disrupts the intercellular signaling and energy homeostasis. So really, a lot of people don't even realize they have insulin resistance. Some people are pre-diabetic and they don't really understand what that means. And of course, then they're given diets of take out the carbs. But really what we need to be thinking about are the fats. Alzheimer's disease, which is also known as type 3 diabetes, common pathology. A lot of people don't even know that they're setting themselves up for this. And I do want to mention, once you get the disease, Alzheimer's, then yeah, the perfect diet is a keto diet. Because the brain's going to favor ketones, going to favor fats, because you've screwed up the glucose transport. So as a dietitian, I want to make very clear in this video that, I'm going to give you a diet while you're healthy. Once you have a certain disease, then obviously what I'm going to, recommend for my patients is going to be based on whatever disorder they have with the disease. That's right. I need to say that because a lot of people say, oh, but I have, epilepsy and I could never eat that way. Well, I'm not talking about epilepsy, okay? I'm talking about you not getting some of the metabolic diseases and understanding how we eat to not do that. But once you have the disease, obviously things can change and your diet can change. But this talks about type 3 diabetes being the same type of pathology as type 2, because I showed you the biochemistry on it. And in this study, it talks about an increase in ceramides in brains with Alzheimer's and other neurodegenerative diseases, because ceramides differentiate up in the brain cells and they literally cause proteins in the brain that can cause this type of scarring, this, where you can get dementia and Alzheimer's. And in this study right there, it reads, ceramides have been suggested to participate in the neuronal cell death that leads to Alzheimer's disease. And yes, there's many studies that are showing this. And what's also interesting, I find, is that the Mayo Clinic understands ceramides in regards to cardiovascular disease and diabetes, dementia. These may be a real problem. And they're going as far as saying that maybe we should be testing them. So I thought that was interesting. I haven't seen it yet, but I did pull this up. 81% of patients with ceramide risk scores have an 81% greater risk of a heart attack. So it's just worth mentioning. But let's go back to what is a healthcare controversy. Sugar and insulin need to be reduced in the blood to reverse insulin resistance. Well, first of all, I'm in agreement with that statement, but not in the statement that it reverses insulin resistance, because the pathology of the disease, clearly type 2 diabetes, type 3, has to do with that receptor site. Now, we obviously want to try to minimize the sugar and the insulin in the blood, but we have to be aware of the root cause. Excess insulin and sugar in the blood, it is a problem. And it does make insulin resistance in type 2 diabetes worse. And obviously, when you remove the carbs from the diet, you remove the insulin, you remove the sugar from the blood. So that's where a low-carb, higher-fat diet has been recommended by so many healthcare professionals. And it actually lowers the A1C testing, which I will talk about after I talk about some very prominent doctors that are getting great lab results, and they're on the internet. I think Dr. Brewer, very well respected. And I agree with what he's saying, not so much from a dietitian standpoint on the reversal, but I get it because he's advocating a low-carb, higher-fat diet because he's seeing the lower body weight, which improves the lab markers, reversing the metabolic syndrome, and obviously a reduction in medication. Yeah, you start reversing that insulin and that sugar issue, and you start losing weight, just lose weight, period, and you're going to improve your metabolic panel. You're going to improve a lot of things. And what they talk about is the gauge over health is the reduction of metabolic syndrome. And what is metabolic syndrome? Elevated glucose levels, triglycerides, elevated insulin levels. So triglycerides, I'm not going to talk about them a lot in this video, but yeah, eating excessive amount of food is going to increase your triglycerides. Just eating too doggone much. Okay, so the wrong diet, processed foods, even on a low-fat diet, you're going to increase the triglycerides. And triglycerides can be very problematic, and they're so tied to the association with insulin resistance because, once again, they have to do with excess fats, excess food, excess weight, also blood pressure, waist circumference, C-reactive protein, which is just an inflammatory marker, body weight. All these things are metabolic syndrome, metabolic disease, insulin resistance, really, if you want to label it. So I get it, because what happens is, we start reversing metabolic syndrome, let's say on a low-carb diet, because I just showed you how. But it's not long-term, and that's what I want to talk about in this video. And the other thing that other healthcare professionals get really all in a tizzy over is as soon as we start adding in all those fats, we also increase your LDL fats, which is considered the bad cholesterols. But that's not even a good marker, because LDL cholesterols, really, your doctor shouldn't just be looking at the concentrate. They need to be looking at the particle size, and also the number of particles, the ApoB. There's other factors than just looking at your LDL. So I understand where Ford Brewer's coming from. Because he's saying, my God, I put people on these low-carb, high-fat diets, and they're losing like 80, 90 pounds. And look at their diabetes is going down. Well, yeah, let's go back to the biochemistry, because let me just make it really clear. You get rid of a lot of fat cells, and your whole, everything's going to change on those labs. You're going to get rid of a lot of fatty acids. But eventually, if you continue on that high-fat diet, it's going to lead into problems. It's not sustainable long-term. Does seem to get the job done short-term. And where some of this controversy is coming from is that people are losing access to care, which is kind of crazy. Like, when I heard this is going on, I'm like, what? Yeah, doctors are getting all up in a tizzy because they're seeing these elevated LDLs, but they no longer have the metabolic disease. They're like, oh my God, I got rid of my diabetes. I've lost 100 pounds. My blood pressure's gone down. I've never been better. And my LDLs are now elevated, but I got rid of metabolic syndrome. And that to me is part of the controversy. But these doctors are getting all upset because they're only seeing the LDL, and they're going, oh, that means you're going to have cardiovascular disease, all this inflammation in the arteries. And to some extent, they're not wrong either. So let me just go there, and I'll come back to an example of one of my patients. So this is an example of an artery. Here's the little ceramides in there because they're very arthrogenic, causing atherosclerosis, which is that plaque in the artery. But what happens is these compounds, these reactive oxygen species, they oxidize some of these fats that get trapped in this wall. and particularly the LDL fats. And there's other things that can determine that. Like I said, the particle size of the LDL, the particle number. So not just looking at a lipid panel, LDL is the end all be all. Also, the carrier of ApoB. This is also implicated. Not going to get into that in this video. I'm just shedding light why doctors are looking at the research, and it's really a lot of research, okay? I know Dr. Brewer's bringing some research. I see some of the other, but if you look at Journal of American Medical Association, United Kingdom, I mean, all around the world, millions of studies are saying these fats are atherogenic, and they're doing clinical trials, they're doing rat studies. I mean, poor little rats, I do feel bad, but, they are getting some good research from that. So I can't just ignore it, but I can't also not empathize with patients that are saying, I was on a carnivore diet and all my blood work was perfect, but my LDL. Before I started the carnivore diet, I was pre-diabetic and I had high blood pressure. I had fatty liver disease and I had joint pain in my arms and legs. Everything disappeared when my doctor said I needed to stop my diet and he wanted me to take pills for the cholesterol. Everything disappeared. Her metabolic syndrome went away, but her LDL skyrocketed. And what the doctor's looking at is, it's great you lost weight. That's wonderful. We want to give you this statin drug because we don't like the LDLs. So I can understand. I can see both sides of the equation. Now, this person got a little upset about that because she's thinking, I've never been better. I've lost 60 pounds. And this carnivore diet's been the best thing ever for me. Well, of course, she had no glucose in the blood, no insulin in the blood. Of course, she's going to tell her doctor to go to hell. I'm not sure I agree with that. But anyways, I can understand both sides of this equation. But what I want to do in this video is give you a solution based again on science. Let me talk a little bit about some of my patients because I want to throw my patient in the ring as well. A1C, and let me explain what that is. That is a test that measures your glucose over a 3-month period. So we can actually take a blood test that tells us the amount of glucose, the amount of sugar on average that was in your blood. We get a number on that. And if we had a lot of sugar in the blood, let's go back to the example. I'm somebody that always has to have visuals. We go back to the example. So if an A1C was high, it meant over a 3-month period, you had a lot of sugar in the blood. It wasn't getting in the muscle or the brain cells like it should have. Well, of course, you already know that because you see the big old belly fat and you're not really losing weight like you'd like. And this is insulin resistance when it starts, prediabetes as it grows, type 2 and type 3 diabetes when it is further along. So we'll go back to the example of the A1C because, well, let me just show you this. Let me go back to the chemistry of that. Is you can have an A1C, and I just want to throw this out there. You can have an A1C be low and be diabetic. And here's the situation. I forgot to tell you this. When you exercise, you don't need insulin to shuttle sugar into the muscle cell because when you exercise, the transporters come to the surface of the muscle cell. This is the only time that insulin isn't needed to shuttle sugar into a muscle cell. Why is that? Because when you're moving, muscles are hungry for sugar. Transporter comes to the surface. The sugar goes into the cell. So if you're an athlete, you're going to have sugar going into that muscle cell when you exercise, even though you're all gunked up and you have ceramides circulating everywhere. So ideally, your doctor isn't even going to see an elevated A1C, but you can be highly insulin resistant even on your way for type 2 diabetes. It will show up later. Yeah, you'll hit a threshold, maybe age 65, but it will show up. And I do see this with a lot of my athletes when I do a 2-hour glucose test, and I can see what happens when I give them a little sugar drink, and we can see when we take their blood that they do have it, although their A1C is low. So I wanted to throw that out there. So let's go back to the example of one of my patients. And I pulled up some blood work here. So this is insulin-resistant metabolic syndrome on statins. And they exercise 45 minutes a day. Now, they're really shocked because they've now become pre-diabetic because their A1C is 5.7. In A1C for pre-diabetes, it's got to be 5.6 or greater. So my patient's 5.7, so they're pre-diabetic. They also are low in LDL. Look at this. Now, of course, the doctor didn't do particle sizes here, didn't get all the information. Cholesterol's low. We want your cholesterol under 200. They're 129. They're on statins, but they have metabolic syndrome. And this is really a false sense of safety here because the statin is controlling some of those LDLs up here in the artery, okay? So the statin is controlling that. But they still have metabolic syndrome, and they're still going to be at risk. They're still going to have ceramides. They're still going to have other things that they're not looking at. But we cannot deny the fact that LDLs, according to the research, they are part of an atherogenic fat that causes atherosclerosis, that causes this plaque in the artery. So let's go back to my patient. So this is one of my patients that came to me when they first started, and they literally have an A1C that probably would be higher because I look at this really high insulin. So they have a lot of insulin in the blood, and we want your 1 hour glucose. We want that under 130, and they're at 184. So they got a lot of glucose in the blood after 1 hour and after 2 hours and a lot of insulin. So if we go back to our example, let me show you what they look like metabolically. This patient has their sugar in the blood. They also have a lot of the insulin in the blood. So they're a situation where they've got insulin and they're hungry. This person is definitely struggling with their weight. They do have a high circumference when they came to me, couldn't lose weight, had extra 40 pounds, struggled to get it off. But this is what they look like. A lot of insulin and a lot of sugar. And their A1C isn't as high as it should be because with that type of glucose in the blood, 107, and fasting insulin, normally we'd probably see a much higher A1C. But with this person, they exercise. So their A1C was a little lower. It's not going to show up right away. But they're well on their way. And by the way, they didn't even have prediabetes a year ago. So it's just slowly starting to creep up because more and more of those insulin receptor sites are getting, disabled. So bottom line, is it better to have elevated LDL fats and no metabolic syndrome? Or is it better to have low LDL fats on statin therapy and have metabolic syndrome? Well, first of all, a little caveat. LDL is really a poor indicator of risk. Let's just say that. We need to look at the LDL particle number and size. We need to look at the ApoB carrier. We also need to look at certain genetics because cholesterol does play a role in synthesis and absorption. I'm not going into that with this video because the point I'm trying to drive in this video is that instead of trying to get a diet that's going to maybe contribute to more fatty acids, why not understand the nutrition? Okay, I'm a dietitian, so this is my camp, right? Macronutrient ratio. There is a reason why protein, fiber, carbs, and fat need to be at a certain ratio for the day and at meals. This is not like weird, quacky stuff. Registered dietitians, we're in the thousands. We get licenses understanding the importance of these macronutrients and the role they play in our body metabolically. Okay? So I understand the frustration. She's eating a carnivore diet and she's getting rid of metabolic syndrome, but she's really not. She's just putting a Band-Aid on it. And that's the point I'm trying to make. And I applaud her for losing the weight. And I don't want to be a, Debbie Downer here. It's a good thing, but it's not a lasting thing. So I'm going to really drive home the fats. I think in other podcasts, I really do talk about balance being understanding how these ratios work in meals. how they work at the end of the day. I have a membership I can tell you about. You can join. I'll do a little commercial plug. And that's all I do. One night a week is I work with patients, work with people, teaching them how to do this so they're not having to do the other. Because that eventually catches up with you. It's not sustainable. So let's just talk about fats. How much do you need? You take your ideal body weight and you divide it by 3. Not your current body weight, because I don't care what you weigh now, because you may be 60 pounds overweight, and that's certainly not ideal. So, macronutrients are based on ideally what you should be, not what you are now. That's why a lot of people get confused, because they think, oh my God, if I ate 45% of carbs, I'd be big as, that'd be too many carbs. Well, of course it would for what you weigh now, but not for what you should weigh. And that's the same thing with fat. So I put fat anywhere from 25 to 35%. That's just not a low-fat diet. That's just what it should be based on your ideal body weight calories. And what is ideal body weight? A lot of people say, oh, I know what my ideal body. Well, there's a scientific way to know that, so why don't I just go over it? So you take, for women, every inch over 5 feet, you add 5 pounds, and you add it to 100. So if you're 5'4", that's 120 pounds. You can easily add 10 pounds to that and still be within your BMI, although I'm not a big fan of BMI, but you'll still be within a healthy range. And for men, for every inch over 5 feet, it's 6 pounds plus 106. So if you're 5'10", 60 pounds plus 106, that's 166. You could easily add 10 to 15 pounds on that and still be within your ideal body weight. I do have to have a little caveat: highly muscular, larger frame. Yep, it works. So you can take that number divided by 3. That's going to give you 25%. And then you add 20 grams, and that's your range on average. So for the woman that was 5'4", she's going to have her fat grams range between 40 and 60. Okay? That's going to be a range, approximately. Okay? So that's just saying, look, macronutrients mean something. And it's not just you deciding you're going to do it or not do it. And I understand, you're at a point, you're morbid obese, you got this insulin resistance. It might get you down the road to reversing the metabolic disease, but at some point, you're going to have to come back to reality and sustainability and understand that fiber and carbs, these play a role in your not only gut health, but your muscle health as well. So I wanted to kind of drive this point home, give you what the solution is. The key takeaway, I should say, is you do need to know your amount of fats, because excess amount of fats, not really advised. Okay? And I'm, once again, caveat, right? I'm not saying that if you don't have a special medical condition. I'm not saying that. I'm saying my average person trying to be healthy. And you want to balance carbs with protein and fiber. Because when you add enough protein and fiber to your carbs, you will slow down the entry of the carbs into the bloodstream. You won't have a big rush. So it's more about balancing the carbs, understanding what your plate should look like. And this is an example. A lot of vegetables, the beans, which provide the carbs, the brown rice, making sure we have a lot of protein and a lot of fiber to slow down the entry of those carbs into the bloodstream. Obviously, the more diabetic you are, I'm going to be upping more protein and fiber with those carbs. But we can't just ignore the carbs. They're an important part of your diet. I also want to do a little plug for my book on Amazon, where I really teach you why your diets fail, perfect example, and the science that really works. Understanding how these macronutrients work and why they're meant to be at the levels they are. Also, you can join my membership. You can go to myrnamethod.com. Love to see you there. We really take a deep dive on how to eat to reverse metabolic diseases. Eating, normal. I want to say normal, eating food, right? And not eating mono diet. So I also want to thank everybody. I've reached a milestone, over 700 followers, so thank you for that. Don't forget to subscribe, like, and we will check the chat. Sammy, do we have any? Awesome. Okay. See you guys next week with another interesting tidbit on nutrition to impact your life.